All right, welcome everybody to our lunch session today. Of course, continue eating, continue chatting. This is more of an informal thing. Thank you to BMS for sponsoring this lunch symposium, which is entitled Bridging the Gap, Turning Guidelines into Action for Resectable Non-Small Cell Lung Cancer. All right, so this is the agenda for today's presentation. So this is really going to be a multidisciplinary discussion, trying to integrate everything that we've learned over the last 2 days and how we can really incorporate this into clinical practice and incorporate this maybe into guidelines, where the guidelines do well, maybe where some of the gaps in the guidelines are. So we'll start with a little bit of an opener, which is this, and then we'll speak from the respiratory physician's perspective, the pathologist's perspective, both before and after surgical resection, surgeon's perspective, radiation oncologist, and then concluding with the medical oncologist. So these are the commercial disclosures. This is our esteemed panel, and thanks to everybody for their contributions. My name is Darushka Naidu. I'm a consultant medical oncologist from Dublin. We have Jason Agulnik, who's a respiratory physician from here, Montreal, Canada. Dr. Pierre-Olivier Facette, also from Montreal. Dr. Andrew Giles from Kingston, and Dr. Huda Baheg, also a local from Montreal in Canada. These are our disclosures. So the purpose of today's lunch symposium is really to go through and discuss some of the consensus, where consensus does occur, and controversies in the current guidelines, to identify practice gaps in the treatment of our patients so far, and to obtain the expert opinions of a real-life MDT on real-world experience. So taking a step back and try to integrate everything that we've learned, forward thinking into what we're doing today. So this is the patient journey. So we're going to go really from the beginning all the way to the end in the early stage setting. So the initial presentation, the initial considerations with respect to staging from our pulmonary colleagues, then pathologic assessment prior to neoadjuvant chemoimmunotherapy, surgical considerations, then postoperative pathologic assessment, and then, of course, the systemic treatment considerations from radiation oncology and medical oncology and follow-up. In order to participate in this, it would be great if everybody here can take part using Slido. So you can scan the QR code here with the associated code, and it will allow you to participate in some of the polling questions. Hopefully, we can have a nice back and forth about that. So, in order to anchor this discussion, we're going to go through a couple cases and one central case. But starting off, which patient cases do you put forward for your discussions at your multidisciplinary tumor boards in the early stage setting? Would you focus on only stage 3? That's the first option. Only borderline resectable. Other patient factors, for example, comorbidities, maybe comorbidities that might limit one treatment decision or another, or all patients. Okay, we might give you a second to vote. Oh. Interesting. So it looks like just about half of respondents at their tumor boards discuss all new patients. And then some have selected criteria, patient factor, stage 3, and borderline resectable, or slightly less. So I think that's really important to frame our discussion, and also shows that really this discussion does apply to all stages of early stage lung cancer. So we're going to root our discussion today in a case. Thank you to Dr. Pompili for supplying the case. This is a 75-year-old woman with a history of angina, PCA 5 years ago. Lives alone, presents with fatigue, dry cough, and an abnormal lung mass at the left chest. CT scan demonstrates a 4 by 2.5 centimeter necrotic mass in the left lower lobe, a suspicious 10L lymph node. PET CT demonstrates that both these areas are FDG avid. No metastases on brain MRI, and on EBUS, we see that the 4L lymph node is positive for non-small cell lung cancer not otherwise specified. All the other lymph nodes are negative. In terms of biomarker testing and clinical assessment, the patient's ECOG performance status is 1. Biomarker testing, there is a genomic alteration identified, KRAS G12C, and the PD-L1 expression is 90%. We see here in terms of pulmonary function, Broadly, the patient appears to have reasonable pulmonary function, DLCO of 62%, FEV1 of 96.7%. So in summary, this is a non-small cell lung cancer not otherwise specified of the left lower lobe, T2BN2 single station lymph node, stage 3A non-small cell lung cancer, PS1, and a reasonable lung function. This is the imaging, both on CT and on PET-CT. So armed with that case, we're going to go into our discussion first from the respiratory physician's perspective. Welcome, Dr. Algonek.
Thank you. So I'm going to discuss the role of the respirologist and how we are part of the multidisciplinary team. So we often see patients, the patients often come to us either through the GPs, whereby they have symptoms and they get worked up. Sometimes they get worked up for other things and they find incidentally a lung lesion. Often they come to us also through the hospital, through the emergency room, where they show up either with lung symptoms and undergo workup, or they show up with other symptoms and, for example, have a CT scan of the abdomen, and then they see the lower cuts of the lung and they find a lesion, and then they end up getting worked up. And even more so in the future, we'll start to see more patients for lung cancer screening who get worked up by the family physicians. So the role of the respirologist or the pulmonologist, depending where you're from and what term you like to use, number one is to diagnose the patient and to stage the patient. And I'm going to say that in general, the respirologist or pulmonologist, there's a whole spectrum on their interest in lung cancer. And so some really have minimal interest and minimal understanding sometimes, and others. In Quebec, we're actually quite unique, where we have a bunch of respirologists, I would guess at least a dozen, who have an interest in lung cancer and who treat lung cancer like myself at the different centers. So the importance is to understand that when you're diagnosing the patient, you try to stage them at the same time. Then you would determine if they're a surgical candidate, and you get the pulmonary function test. In this particular case, the PFTs were actually quite good. If they're borderline or they're not that good, you may then consider doing a perfusion study, a VQ scan, specifically the perfusion part, or an exercise test and seeing what their VO2 max is. You would then also try to optimize their respiratory status if you felt that if they were going to go for surgery or even for any treatment. Try to get them to quit smoking if they're still smoking, treat their obstructive lung disease, and even consider, if they're going for surgery, pre-op rehab programs. The makeup of the multidisciplinary tumor board is, depending obviously on which center you're at and who's available, is very variable. At the top of the list is always the medical oncologist, radiation oncologist, and thoracic surgeon. But I would say don't forget some of your colleagues. So I would say that it is helpful to have a respirologist, a pathologist. We have a nuclear medicine radiologist who joins us. Also the allied health professionals, such as the nurses. We call them nurse pivots in Quebec, who specialize and are assigned to the patients. And you may also consider inviting the pharmacists, if they're available, the oncology pharmacist. And sometimes there's dietitian or physiotherapists who are involved in your team. The research team is very important, especially to try to enroll patients in clinical trials. And this also goes back to the biopsy, in that if you're considering a patient for a clinical trial, think about that when you do the biopsy, because even though the technology has advanced and we have smaller and smaller needles and able to get all the tissue that we need and get all the results that we need for clinical trials, you actually need more and more tissue nowadays. So if you're considering a clinical trial, think of trying to get the biggest piece of tissue possible so that they can get enrolled in the clinical trial. And finally, the tumor board is very educational. We invite the residents or students to join us. Sometimes they present cases and sometimes they just watch. But this way they get to see the discussions amongst all the different subspecialists. So which patients to present? So we saw from this group that about over 50% present all cases. And there really is no right answer to this. It depends on your group. So it varies by the different tumor boards. It depends on the patient volume. So obviously, if you have huge volumes, you won't be able to present everyone. Should you present all new patients, all stage 3s, all complicated cases? And that's something that the group has to decide amongst themselves. It is a big benefit to the patients when they're presented at these tumor boards. It's the equivalent of getting multiple second opinions at the same time. And sometimes it actually speeds things up for the patient, so they don't have to wait several weeks or months to see the other specialist, because a decision is made within a week. and then the specialist may say, no, it's not appropriate for me, so you don't have to waste the patient's time. So what do the guidelines say about multidisciplinary tumor boards? So I found these two articles. The first one's the accuracy of lung cancer staging in the multidisciplinary team setting. And they discussed that the thoracic multidisciplinary team has resulted in more focused and timely investigations for histopathologic diagnosis and disease staging, which translates into earlier treatment initiation. There's increasing evidence that the multidisciplinary team care facilitates and allows access to investigations that lead to improved accuracy of tumor and nodal station, but there is a paucity of evidence on the accuracy of lung cancer staging. The second article is the impact of multidisciplinary team meetings on patient assessment, management, and outcomes in oncology settings, and it's a systematic review of the literature. They found 27 articles, and there was limited evidence for improved survival outcomes at these meetings, but if you look between anywhere from 4 to 45%, depending on the article, of the patients discussed at the multidisciplinary team meetings experienced changes in diagnostic reports following the meeting. The patients discussed at the meetings were more likely to receive more accurate and complete preoperative staging and neoadjuvant or adjuvant treatment. The conclusion was that the multidisciplinary team meetings impact upon patient assessment and management practices, but again, there's another but. There was little evidence indicating that MDT meetings resulted in improvements in clinical outcomes. So again, the importance of the multidisciplinary team, I think it's hard to actually show data, but I think that everyone who participates and for the patients, there is a big benefit. So I'll now pass this on to my colleague, Dr. Fisset.
All right. So there's two parts. So part one, we're going to be talking about biopsies. So one of the challenges in pathology is it's just a small amount of tissue that we have to deal with for our diagnoses. And Jason also mentioned, so competing interests in terms of the diagnosis includes biomarker testing and if there's plus or minus research aspects afterwards. And we're dealing with very small little fragments. So I put a picture on the side here, and this is an example of a biopsy that we have, just a typical biopsy, 3 little fragments, and they're about 1 to 2 millimeters just in greatest dimension. So even with the needles that we aspirate, things break apart, and we have to do our assessment on that. And in this case in particular, mentions that this is a non-small cell lung cancer NOS. That's just a default kind of diagnosis based on the immunohistochemistry, diagnostic immunohistochemistry that we use, and it was just a limited panel because it's just limited pieces of tissue. So we have to make sure there's enough tissue for the diagnosis, but also for biomarkers. There's also questions as to whether and when we should do biomarker testing. Should we do it reflexively on all cases? There's a cost that comes to it in terms of testing, and if all patients should have it. I mean, some will argue that a lung cancer diagnosis in 2025 should come with NGS testing, versus the other aspect is at the request of physician, but that comes at a cost of turnaround time because we're dependent on another actor at the multidisciplinary rounds to tell us to do the testing. And then how far should we go to testing? Right now, guidelines are kind of on the fence as to whether squamous carcinoma, should we just restrict it to non-squamous, non-neuroendocrine carcinomas? I think there's evidence that suggests that we should move to a broader testing. And then turnaround time. The case, if it's from an external institute versus an academic site, I think that plays into those aspects. Where an academic site, the biopsy would be done on site, and then the pathology assessment and the biomarker testing will all happen. So that will be a very quick turnaround time versus another site where it has to be sent out. And then finally, the post-analytical aspect is getting the report to the right time. In Quebec, we're plagued with fax machines and sending things out to other centers, and then the faxes get lost. So that also plays into the turnaround time. And then finally, in terms of if we can't get to a diagnosis, if it was a difficult biopsy to perform and we have a negative or inadequate result, should we consider liquid biopsies as an alternative? So in terms of guidelines, we don't have that many. There's a few in terms of like the main one, I think, is the WHO, the 5th edition, is we should just conduct the minimal immunohistochemistry to preserve tissue for biomarker testing. Recommendations for turnaround time are essentially as quick as possible. NGS will take longer. As panels become bigger, the analysis will take more time too, but we're trying to keep things under 14 calendar days. And then the idea of liquid biopsies, I think, was explored yesterday. But as it stands right now, the guidelines suggest, like the NCCN this year suggests that liquid biopsies is a good alternative in case if it's a difficult biopsy or inadequate or unsatisfactory diagnosis from the initial tissue biopsies. And the liquid biopsies comes as an alternative, although it faces challenges in terms of sensitivity, where a negative test may not actually be true, it might just be a false negative. So that's pathology part 1. I'll see you later.
Okay, so there will be no controversial superhero capes for this talk, nor will I be replacing John's face with my own. But I do have a question for the group. So at your institution, how many patients who have gone through neoadjuvant chemoimmunotherapy make it to surgery? I'll give you a minute to respond. Do I advance the slide? Or does it just show up? Ah, there we go. Okay. So we have some high-performing, most of us are doing pretty good. A couple of groups that get all their patients to surgery. That's great. So from the standpoint of operability and cancellation, safety, these are a few areas where I think the experience varies. What I'd say about operability, and I think most people are coming around to this conclusion, and it seems fairly intuitive to say that you shouldn't be wondering if the patient's going to become operable, right? You should probably determine that up front. There's some limited data to say that the FEV1 does actually improve modestly by about 10%. I'm not sure that that translates from a patient who wasn't operable to who is operable. You can start someone on treatment if you think they're operable and get further testing if you want to see PET and so on. Approach I haven't included here. I think it's less relevant what you do, whether you do a thoracotomy, VATS, robotic. There's some quality of life data from, I think it was Checkmate 77T, that showed that the difference between a thoracotomy and VATS is really relevant only in the short term. After 3 months, it seems to be about the same. So you should do what's safe, what you're capable of doing to ensure an adequate resection. Cancellation was on the higher side in the trials. Is it definitely a concern that people think about? But anecdotally, and people have been expressing less concern. In our institution, it's 7%. Only one patient who didn't go to OR because of progression. You could say that test of tumor biology, this is something people talk about. I also wonder if perhaps those who are not proceeding to OR, it's also a test of physiology. What happens when they go through chemotherapy? Would they have been a candidate for surgery, or would you have ended up with major complications? So perhaps it's not as unrosy a picture. And then in terms of safety, one concern that surgeons have is that the major neoadjuvant trials used more oncology-related AE reporting, but some of the real-world data that's starting to emerge is showing in these metrics that we look at as surgeons that the safety results are pretty similar. One area of controversy is upfront surgery versus neoadjuvant chemoimmunotherapy. many of the guidelines are on the older side, but we are starting to see emergence of some consensus statements, so STS, ISLC, and there's a Canadian consensus, and NCCN is keeping up, although softer statements. I think one of the most useful statements comes from the this survey, which says that for surgeons, there's really no equipoise for stage 3. You know, for those who can receive surgery, neoadjuvant, and we're probably never going to see a upfront versus neoadjuvant trial. There is controversy for stage 2 patients, and I'd be interested to know what others' experience are. My own personal opinion is if the patient has a 4+ centimeter tumor, means they're likely to get adjuvant therapy, and at least for my patients who are coming from further away, I think that they're more likely to complete a course of neoadjuvant. So even if it's just that logic, but hopefully that will be addressed more in the future in trials. And then finally, resectability is an area that has some heterogeneity, I think really inherent to the tumors themselves. You know, as we've talked about in other talks, it may not necessarily be as much about the anatomy as the physiology. So I think you really can see that reflected here in that yellow zone where there's poor agreement for N2 multi-station disease, and it sort of filters down into the larger tumors plus minus invasion with N1 disease, N2 single-station disease. These tumors are not all behaving the same. They're not all invading the same structures. And so the most useful definition really comes from the STS consensus document, I think, which in addition to our old definition of an R0 resection, which mostly focuses on the parenchyma or the bronchus or the vascular margins, i.e., is there tumor on the margin? We should be thinking about this as, can we actually achieve clearance? And that should be informed as well by the overall biological picture, not just, you know, what we're physically taking out at that time. And should it include lymph nodes, perhaps more than we've been thinking? Patient I operated on recently who had stage 1 lung cancer but had unexpected 4R disease. You know, how much of an R0 resection is that, even though it's reported pathologically as R0? And I think one thing that we perhaps are not thinking about as much in this room, where most of the people, surgeons at least here, are pretty invested in lung cancer care, probably have a strong focus on oncology, perhaps have a higher level of comfort with advanced lung resection techniques. A lot of lung cancer surgery is being done in the community or in places that perhaps surgeons are not comfortable with these techniques. And so what happens to those patients? So those patients getting referred for second opinions, NCCN suggests that they should be referred for a second opinion, but that may not be common practice. What about lymph nodes? I was always taught that station 2L and 4L were out of reach for a surgeon. Are those resectable? Curious to know what other surgeons think. We've been resecting them routinely, but not a common scenario. So I think that's where the tumor board comes into play, and it comes into play with the surgeon's personal experiences and tolerance for being able to get the patient through and hopefully spare some lung if possible.
Hi, me again. So we kind of surround the pathologist like a hug, right? I think that was the theme today. I think it's make sure to hug your surgeons too. I didn't hug you this morning. I'm sorry, John. I'll do better. So the pathologists don't get enough hugs. Resections. The assessment of the neoadjuvant is one of the controversies that we're dealing with. I recently just looked at our numbers, and right now in 2025, 40% of our cases at the MUHC have chemo-IO. coming to the pathologist's workstation. These come with an added workload for pathologists versus a standard case, because there's a different type of assessment, a deeper level that needs to be done. And there's different guidelines as to what needs to be done. The ISLC has their own guidelines. Dr. Dasich presented yesterday this aspect as how to do this. Also, and it seemed to scare a few people in the room. And then there's also this question of weighted average. At least that was put to rest and helps simplify things. But there's another guideline that wasn't discussed. It was actually discussed last year at Last Elixir, and it's this immune-related pathological response criteria. This is kind of a pushed forward by the Hopkins group and a paper by Cottrell et al. And that focuses, maybe it has a better assessment of cases that have neoadjuvant immunotherapy versus other types of neoadjuvant therapy. Another question is how much to submit. I mean, that seems to be and that's the amount of tissue that's submitted for analysis from the tumor bed. And that seems trivial, but at the cost of, I think it's about $500 to $1,000 per additional block for pathology case, and because that includes the work by the pathology assistants, the technicians, and all the different parts of the team in the pathology side that lead to get a slide to pathologists to look at with their eyes, or with a microscope or a computer. And then the question of lymph nodes, how do we assess those? We just say yes or no, they're positive or negative, or should we assess them? From what the guidelines say, the ISLC, I think, can win versus the IRPRC because it's simpler, it's faster, and maybe more universal for centers that don't have digital pathology. The aspect of weighted average, I think, can be used, but it's not necessarily going to add much benefit, at least for a decision as to what MPR or not. But that's another issue too, is what is MPR? We put it as 10%, but maybe that number isn't quite right. And also, as in this case that we're presenting, what do we do when we have a YPT 0, but there's an N1? The ISLC recommends to consider this as an MPR case, but there's no real good data as to what this is. It's still developing. The IRPRC can give maybe a better assessment of IO cases, but it's a more difficult assessment to look at in terms of regression bed. And then the lymph node assessment, I think, is important. And how to assess them, that's still not quite clear, but at least from the IRPRC group's point of view, assessing the regression bed and even the lymph nodes needs to be done. So that's an additional challenge for pathologists. And hopefully AI will help. That's maybe the theme, I think, worldwide. We're hoping to implement that, and Dr. Dasich, I don't think she mentioned it too much yesterday, but her group was part of an ISLC group to look into this question, whether we can be successful with AI. All right, thank you. We're done.
So I just noticed when we sat that it was a case about resectable. That was the title. So, and also they're asking for the radiation oncologist perspective after the surgery. So why am I even here is the question I have. But I'm happy to go over this. And I realize I have a tough crowd today, mostly surgeons. But I want to show you here that I'm here in very good faith. So we were asked to discuss the challenges and then go over the guidelines. I reverse things here. I'm going to tell you about the guidelines, and then we're going to discuss about some of the challenges. And really, it's in an effort to show how I am here as a friend. So you could see my name just before Normand Blais. So I have endorsed these Canadian guidelines, where essentially we're saying that for stage 3 disease, there is really no, we can consult a radiation oncologist if a patient is physically unsuitable for surgery, declines surgery, or R0 resection is not possible for a borderline case. Pan-coast chemoradiation with resection potentially is considered standard, but we've accepted that for selected cases, the paradigm of neoadjuvant perioperative treatment could be an alternative. And there's really no role for port in N2 disease unless there are positive margins, and this can be discussed case by case. So I have endorsed this. We can all agree on this, I think, in this group. Now, on one side, from the radiation perspective, we have the Pacific trial, which you all know. And I put here stage 3 unresectable with a question mark and brackets because really, this is a trial that's now starting to be outdated. It was first published in 2017, and the majority of patients had stage 3A disease as per the 7th edition. And I think the definition of resectability has evolved significantly in the meantime, at least in many centers that perform a lot of neoadjuvant or perioperative treatments. And I think if we were to rerun a new Pacific trial today, the patient population that we would enroll, at least in centers that operate quite a bit, would be quite different. So I think many of the patients in Pacific were resectable, quote unquote, as per today's standards. And in parallel, we have this growing number of studies testing neoadjuvant, perioperative, etc., where, of course, they define initial resectability as something that is required, but the term, as Dr. Gals has suggested before, is a very difficult term to define. And again, here, bear with me. I know this is a surgical crowd, but I'm going to try to raise some points, some challenges, discussions. But if it gets uncomfortable, remember that I have endorsed the initial recommendation. So first of all, can we say that the standard of care in all the peri-neoadjuvant trials arm was a bit controversial in the first place, with the selection of neoadjuvant chemotherapy followed by surgery as a standard of care in Checkmate 816, for example. So challenge number one, I think it's important to, again, these are just ideas, think to a bit food for thought. There really has not been randomized control trials that have identified which local treatment is superior in stage 3 disease. We have these, albeit outdated studies, but this is still the only thing we have. The intergroup trial, the EORTC trial, the ESPATU trial, which all showed that the addition of surgery versus definitive radiation did not improve survival. And this is what we have as data. And now, even if we dig in, this is, for example, the intergroup trial, the majority, 75% in this trial, had only one node N2. So for us, it's obvious, the previous case we discussed, it's a surgical case. But again, in this exact same situation, it wasn't necessarily proven that in this single station N2, surgery is the standard of care. Silence. And then the second challenge, I think, as was mentioned, is the definition of resectability, and I think we can all agree on this. This is an effort which was discussed before from the EORTC to try to define resectability. And I know John Spicer doesn't really like this effort because it tries to use anatomy to define resectability, and I get that it's not necessarily the optimal approach, but it's an effort to have a common definition. And in this consensus, they defined that N2 multi-station, non-bulky, non-invasive was potentially resectable, T4 potentially resectable, and they kind of overall agreed that bulky N2, N2 invasive, N3 was unresectable. And I get this part, and especially in the context of the MDT bridge study, which we've heard a lot about in this study, in this conference, is not necessarily a definition that makes surgeons very comfortable. And from a surgeon point of view, and I've had this discussion with John before, really, when we look at their guidelines, what's resectable is if a surgeon is able to tell you that they can do an R0 resection and complete their lymph node evaluation. This is great, and I totally understand and get that. I find the only issue with this is when we discuss and we talk about being multidisciplinary, in reality, the main decision is on the shoulder of the surgeon. And really, the paradigm of treatment is decided by the confidence or the comfort of the surgeon to operate. And there creates a lot of variability. And this is not necessarily a bad thing, but it is something to keep in mind. By the way, this with AI, it was supposed to look like John. I'm not sure it's really working. The third challenge, and I think this we've seen many times, and I'm showing the data from Checkmate 816, but it's the same thing in the perioperative study, so it's not really neoadjuvant, but neoadjuvant or periop. We've seen the numbers. It was discussed. Maybe they're not exactly those numbers, but in general, it's quoted that about 15% of patients don't make it to surgery. And we always talk about this with these patients would have made it with chemoradiation anyways. I think it's a big question mark, but I think the other 15% of patients that we should also add to this are the patients that have microscopic disease or macro-microscopic disease after surgery. So for me, these are patients that were poorly selected and considered resectable. So quote unquote, if we think about the numbers in Checkmate 816, we often quote that 16%, but it's more about 30% of patients that were perhaps poorly selected for this approach. I see John, really, and if John is uncomfortable, I know, but remember, I endorsed the guidelines before. And then the fourth challenge, which we discussed yesterday, is that most recurrences after chemo-IO or IO, either neoadjuvantly and periop or adjuvantly, are locoregional. So we have from Checkmate 816, essentially what it shows is immuno works. And I think really the idea is both Pacific and all the periop neoadjuvant studies are showing that immunotherapy works, but we still haven't clarified what's the best local treatment for these patients. And if we look at Checkmate 816, the local regional recurrences between the chemo or the chemo-IO were similar. And in the Empower trial and adjuvant setting, the local regional recurrences are the most common recurrences in these patients. And those that had a higher PD-L1 score had even more local regional recurrences. So something is pointing to the fact that we need to do better loco-regionally. And this brings me to the question of port in this space. So again, in the guideline, we said for N2 involvement, no real role of adjuvant radiation. And this is mostly based on the Long-ART trial, which was a trial of N2 disease where patients in the pre-IO era were randomized to port or no port if they had N2 disease, either known initially or after pathology. Now, this trial, they were randomizing patients as of 2007. So you can imagine that the patient population of the patients that were operated is very different. And in fact, there was only about 30% multi-station N2 in this study. But if the trial is negative, but if we look at the details, so in terms of mediastinal relapse, it was more than half in patients that had ports. And if we look at the subgroup analysis, patients that had 2 and more lymph node station and that had extranodal extension had an improved DFS. So the question here is, should we revisit this question, especially now that we're doing better distantly and we know that our bigger problem is locoregional disease? And so it's just an opportunity here to tell you about a trial that we're starting that is the rescue trial, and that assesses the role of port, revisits the role of port in the context of N2 disease that did not achieve a pathological complete response. And this is it for me. Hopefully I don't have too many enemies now in the crowd. Remember, I really, really love working with our surgeons.
Don't worry, the medical oncologist will protect you. Okay, so the last member of the team, going to start with a question. So what patient or tumor characteristics would lead you to select a perioperative option rather than a neoadjuvant option? And of course, we had a very entertaining debate about this yesterday. So let's see who really won the debate based on this. So select all that apply. Non-PCR, PD-L1 less than 1%, RVT, mentioned by Dr. Dasek, R positive resection, which Dr. Bahig just went through, and none. Neoadjuvant is enough. Okay. I like this. You can see how everybody's changing their minds in real time. Okay, this is very interesting. So pathologist is king. Percent RVT is certainly something that appears to be coming out very strongly here, really interesting. And then, of course, the clinical other characteristics, non-path CR, also pathology. Neoadjuvant is enough, only in a quarter of respondents. And then our other factors, PD-L1 negativity and positive resection margins. Okay, really great topics, I think will inform some of the discussion and hopefully some questions to our experts. So coming back to our case, which we started with, the 75-year-old woman with single-station N2 stage 3A non-small cell lung cancer. So she is treated with the Checkmate 816 regimen, 3 cycles of neoadjuvant nivo plus chemo. She then receives a left VATS lower lobectomy. Her postoperative course is uneventful. And then good news, she has a complete pathologic response, and that there is no evidence of tumor either in the primary tumor resection bed or any of the resected lymph nodes. We have some mild interstitial fibrosis changes, some mild organizing pneumonia, but nothing of concern. So the lung MDT, this case is then brought to the lung MDT, and based on consensus, adjuvant treatment is deemed not mandated. The patient was followed up in the survivorship clinic with no adjuvant therapy, a 4-month CT scan with no evidence of relapse. So thinking ahead from the medical oncologist perspective, obviously this is an example of the best case scenario. Somebody has been treated according to our proposed guideline, they've done very well, their first scan is going well. But leading up to this, what are the questions that are going through the minds of the medical oncologist and I think the patient in order to get us to this place? So we've heard a lot about pathology, but I think, again, the turnaround times. Many of the turnaround times that are quoted might be quoted from the time the specimen reaches the lab, but the patient might have waited a significant time before that happens. So what's the real-life turnaround time of PD-L1, the turnaround time of EGFR and ALK, and are these biomarkers going to be sufficient alone? Or when are the other biomarkers going to come into play? Did we get enough tissue? Are other biomarkers going to be relevant very soon? Then this idea of patient selection. We heard about the patient experience earlier. Are there any autoimmune comorbidities or other comorbidities that may limit our ability to treat with this approach, particularly idiopathic pulmonary fibrosis? What is the benefit in PD-L1 negative disease? Obviously, in this case, patient had a PD-L1 positive 90%, so we felt very comfortable. But in the PD-L1 negative, still some debate. And then what is the benefit in the 1Bs and 2s? Is it as impressive? So we heard a lot about this yesterday. What are the guidelines and how are these informing where we are now? So as many of you may know, in medical oncology, we have the ASCO, the NCCN, and the ESMO guidelines that we routinely follow. Interestingly, the ESMO guideline for early stage lung cancer hasn't been updated since 2017, so this is ongoing. The ASCO is a living guideline, but only for metastatic disease. So that is going to change very soon. So the only living guideline for early stage lung cancer that's updated every 3 months is NCCN. And we see here that some of these concerns are very front and center. So molecular testing currently needed for EGFR, ALK, and PD-L1. And this is certainly, from a medical oncologist perspective, a rate-limiting step as to when you can proceed with your treatment decision or not. We see here that these are indeed what we see as the clinically relevant subgroups. So as Patrick and many showed yesterday, in 816, the PD-L1 negative subgroup does not appear to gain as much of a benefit. The 1Bs and 2s is also a question. And then obviously the other subgroups all laid out here do appear to have benefit. Interestingly, in Keynote 671, we see something similar, but also calling out never smokers. And this may hearken to the fact that there are rare oncogene-addicted subgroups that may not derive as much benefit from IO. Of course, these were not mandated to be tested prospectively in the context of these trials. So perhaps never smoking status is a bit of a clinical proxy for this subgroup of patients. And then patients of the age of 65, and this is a trend that we see consistently even in metastatic disease. And this relates to the hypothesis of immunosenescence. Is there a possibility that our adaptive T-cell response is less agile the older we get, and we may not mount as durable an immune response? But in the early stage setting, I think so far this is the only trial that demonstrates this trend. So with that, I think this has given us a lot of food for thought over the last 2 days in early stage lung cancer, what are we ready to take into our clinical practice? What's still a research question? And what are the areas that we're still struggling with day to day and in our guidelines? So with that, again, if you can scan the QR code for an evaluation, but if there are any questions for any members of our panel, please come up to the microphones. Thanks very much.
I have a question which is born of my naivety. In ALK, for example, we are starting to see now patients in the metastatic stage undergoing considerable lung cancer surgery, be it lobectomy, pneumonectomy, etc. And I see that's not addressed here because we're only got to stage 3. What is the future for lung surgery in metastatic disease when we know it's only palliative?
I'm sure the surgeons can, or maybe I'll use this. The surgeons can speak to this a little bit better than the medical oncologist, but I suppose that's coming back to the presentation by Dr. Antonov yesterday, that in patients who sustain a very impressive response to a targeted therapy, is there a role for surgery? And again, Dr. Spicer alluded to this as well. In the case of oligoprogression or oligometastatic disease, what does surgery add? I think we have quite a body of evidence in the EGFR mutant lung cancer space, led by some of the leaders, Canadian and others, showing that in a selected group of patients, this may lead to long-term benefit. In the ALK space, my understanding is there isn't a dedicated study that is assessing this, but I think it's an open question. Obviously, ALK is not as common a tumor, so to do that prospectively, I think would be challenging, but perhaps that's an area where our partnership with advocacy could really help us to understand. Can we create real-world databases to understand this and help folks make decisions? But maybe I'll hand it over to surgeons for chat about that.
It's a great question, and I think we've had a couple of really important talks from Dr. Antonov and even Dr. Rousseau yesterday talking about the surgeon's mindset. The surgeon's mindset, I think, historically has been, there's a tumor in front of me, can I get it out and cure the patient of cancer? And now that we have so many or some medications that can seemingly alter the biology of the disease or impact it greatly, potentially prolonging survival, we might have to be much more flexible about our approach. Local consolidation is perhaps a better way to think about it. And so, as an example, I recently had a patient who had stage 4 ALK-positive lung cancer, metastases to multiple bone sites and brain, as well as a large tumor in the lung. The tumor in the lung shrank. They gave radiation to the other sites. 7 years later, she had regrowth of the primary lung tumor, which there is no other treatment for, and we resected. And maybe, who knows how it escaped the, alectinib, but it did. So, if we'd waited much longer, that tumor was going to progress into a critical structure. So, I think it's inarguable for that person there's benefit, but it's going to have to be case by case, and probably that applies to other disease sites as or not disease sites, but lung cancer subtypes as we get more effective therapy.
Also, I think that's also the benefit of the tumor board, is that you can bring patients, back and discuss them again. And when things change over time, obviously you want someone to be a big advocate for the patient, and each case is individualized, and then they could be rediscussed, even if initially there's not surgical, but 3 years later things have changed, then that may be something that people will consider.
Maybe in the absence of questions, or while people are percolating their questions, I might ask Dr. Bahig some, I think, great talk, great highlighting some controversial questions. I really like your trial idea of trying to understand what's the role of postoperative radiation in the era of chemo-IO. This is something that we always debated at our Hopkins tumor board, and it comes up every now and again. But what is the primary endpoint of that study, and how was that debated or decided?
Yeah, so it is as a disclaimer here, it is a trial that is meant to be very pragmatic. We're running it with academic funds, so no pharma, and so far no big grants to support it. So we decided to go ahead and start the trial because we felt there was a window of opportunity. And so the choice of endpoint and the sample size are a mixture of both what we felt was relevant as well as some pragmatic aspects. So at the moment, it's event-free survival at 3 years. Very similar to actually the Lung Arts trial initial design.
So we talk a lot about the tumor board, but or maybe in Europe or in France, I know that every case has to be discussed at the tumor board, and I can tell you in Montreal, very few cases are discussed, or in our institution, just the very complex cases. So where the pendulum should go? Is it in Europe, or I don't know, in Ireland, is every single cases, you spend 5 hours, like in France?
Yes. You should see how long his tumor board is, much longer than mine. There's 4 different institutions come to one central tumor board. In mine, it's 3.
No, but can you, because in Canada at least, the tumor board is quite short, so can you tell about the European experience of the 5-hour tumor board?
The European experience will put hair on your chest. So usually, I'd say the average number, and Patrick can give his experience as well. Our average number in the tumor board is 35 to 45 patients, and every single case is discussed. Every newly diagnosed case is discussed, and that's also for data that is populated into the National Cancer Registry. So we have a central database for where all the cases are sort of annotated, and then also that allows for collection of sort of patterns of what treatments are being evaluated, and towards a national lung cancer audit, which Neil Narvany is here, so he does the national lung cancer audit for the UK, so I'm sure it's quite a similar experience. Patrick, do you want to?
Yeah, so I think it's largely a quality control measure, so every patient who's diagnosed with lung cancer has to be discussed at the tumor board, so whether it's stage 1 to 4, and it's a pretty efficient, like I think last Monday we had 45 patients and it took about 2 hours and 20 minutes, but it's done every week, and there's an intention to get through those patients, and it's not done in a kind of haphazard fashion, but I think as Druska does, it allows for standard care across the country, which is probably the same in the UK and some other European countries.
Can I just add, I think John mentioned that from his experience in China that AI has a role to play in at least these long tumor board lists in terms of prioritizing patients, or even deciding kind of the management patterns and what needs to be done.
I have a question for the group in Dublin. So you go ahead through all the cases, and how is, in the end, and this is where I personally struggle sometimes as a radiation oncologist in tumor boards, because we can discuss, I find everybody can have input and we can discuss over the operability questions, the comorbidities from patients, etc. But how do you, because I suppose one reason why you discuss all cases is to sort of try to homogenize the practice. And how do you do that without really being dependent on how aggressive your local surgeons are? How do you know it's homogeneous compared to other institutions that may have a separate tumor board? And in what sense there is discussion that involves multiple disciplines around the question of resectability?
I think probably Patrick's experience is going to be similar, but so we have 8 comprehensive cancer centers, but 3 of which are surgical. So actually the absolute number of thoracic surgeons that are operating in lung cancer is relatively small. So I think that alone in our situation, and I appreciate across Europe, it's going to be very different. There's actually quite minimal variability, and we have the same surgeons actually that practice at both. So that, can be seen as a pro and a con, but it allows for some homogeneity around the decision making. Anything else you'd add to that?
Well, I think the big difference is that you don't have somebody necessarily, so a patient comes in with stage 1 lung cancer with a, say, 1.5 centimeter hilar node, and they're not operated on right up front. They come through the tumor board, and the medical oncologist has some opportunity to have input. So whereas at Hopkins we discussed, so I still get the tumor board emails, and we discussed maybe 4 or 5 patients a week. So it's and those were almost exclusively stage 3 patients. So the stage 2 and stage 1s don't get discussed.
I think the other benefit that I see anyway as a medical oncologist, and I think hopefully it harkens back to what a patient experience need is, where we're able to coordinate the conversations. In my experience, the first thing the patient hears is very, very formative. So if they hear first they're going to surgery, and you now come later and say, actually, I'd like to do something else, that can be very destabilizing. So usually we try to coordinate that the patient is able to see the medical oncologist and the surgeon on the same day, or within a day of each other. And I know obviously other clinical situations, maybe you have an MDC where you run it concurrently. So I think that's the other benefit to this. Also, our radiation oncologists would chime in and every now and again say, well, hold on, we could still do SABR, or we have an ultra-central clinical trial for SABR. So it does give everybody that level playing field, I think.
This is a comment meant to be both critical of the surgical perspective, but also maybe empowering for the radiation oncology field. The problem we have right now, and I think you narrowed it down nicely, Uda, is that everything seems to rest on the surgeon's shoulders to say, yes, I can get an R0 resection on that. And we do so as an opinion that's based on no data, really, and certainly no prospectively generated data about these features that we see on the biology and on the scans are prospectively associated or predictive of an R0 resection. We have no such data. Only looking back post hoc saying most of the time we get an R0. So that's a problem. On the flip side, where I think the radiation oncology field could really progress is in terms of assuring in a certain proportion of patients complete eradication of disease and total local regional control for select patients based on factors that you can assess prospectively. So we should be asking you, in this patient, what's the likelihood that you have complete total regional control, which is your version of R0? And we should be asking those questions equally to the local therapists about being able, and then the discussion arises about what's the toxicity or treatment profile of the two regimens. And I think that's what we're missing right now in the field, obviously for lack of comparative randomized trials.
Yeah, I think this is a very, very good point, John. And we were discussing some of the cases yesterday with very large tumors, and as a radiation oncologist, I don't like to debate very strongly for radiation when the tumor is very large, because I feel we're not going to be very good at achieving a good local control. And so there are certainly factors we can look at, and studies put stage 3A, 3B, and it's all a big bag, and we don't have that finesse to determine who is best fitted for radiation or who is best fitted for surgery. And I think this is definitely an area where we could do better.
I just wanted to make one other comment about what you said. How do you know, who your surgeons are? What is the local environment? There's so much bias that goes around in these multidisciplinary conferences. If you're in a highly academic center, is it at the end the most respected expert in the field who says something and no one dares to sort of challenge that? Then you have situations in other multidisciplinary boards where I think you do need to understand the skills and abilities of everybody else, from pulmonologists, because pulmonologists want to get the biopsies and they want to use the ion robots and all kinds of things, and then you send it for profiling, and then it comes back, depending on where you send it. If you don't have it locally, it comes back, insufficient quality of tissue, and you cannot get it. And then the question is, well, should we redo it all and then involve interventional radiologists? Should you send it to a surgeon and just resect it, etc.? So there's all kinds of things that happen, and I think, and also, is it a multidisciplinary conference if you have one surgeon, one medical oncologist, and one radiation oncologist, or is it just a bunch of guys, talking to each other? And is it consensus or is it compromise? So I think it's important to be aware of all of these things, and I think it's important to understand your local environment and who you have on your team. And hopefully, over time, then develop some sort of a practice, and also that we should probably be looking at some quality measures of our multidisciplinary conferences and really outcomes that come out of that. Now, obviously, it's more work, and if we hear that, some conferences already run an hour, then at what point do you sort of review some of those outcomes of the decisions that you have made? But I think that's the only way to truly go forward. Also, do you have all providers that understand the data the way we discussed them over here, and the nuances and passions that we have over biomarkers or, individual things? Most of the time in the community is not so. But I think that's the only way to make the best decisions for patients, to really know your local environment.
Okay, well, I think that's actually a really great and very insightful way to close our panel today. Thank you to all of the speakers and to all of those who participated for the dynamic discussion. Thanks so much.